This multiple sclerosis review program is presented by DKB Med Radio.
We suspect that somewhere between maybe 40 to 80% of women and 50 to 90% of men with MS likely have some level of sexual dysfunction, but a meta-analysis has shown that that number is probably somewhere between 60 to 70% for both men and women.
Treating sexual and bladder dysfunction in patients with MS. Welcome to multiple sclerosis review. Sexual dysfunction, bladder dysfunction, both are highly prevalent among people with MS. Both are under-recognized, both are under-managed. Both require the attention of clinicians familiar enough with the symptoms to make an accurate diagnosis and familiar enough with the treatment options to effectively guide their patients. How can MS clinicians acquire this knowledge, and how can they put it to use in their clinics? To answer these key questions, we're joined today by two guests from the Cleveland Clinic. Dr. Lindsay Ross is an assistant professor of neurology at the Cleveland Clinic's Mellen Center for Multiple Sclerosis Treatment and Research, and Dr. Elizabeth Page is a resident in the Cleveland Clinic's Adult Neurology Residency Program. For our guest disclosures and additional CME information, please go to our website, emsreview.org, and select the Volume 6, Issue 10 link. I'm Bob Busker, Executive Producer of DKB Med's e-literature review video programs. Dr. Ross, Dr. Page, thank you both for joining us today.
Thanks so much for inviting us to be here. Really glad to do it.
Yeah, we're glad to be here.
Our overall learning objective for today's program is to discuss the prevalence and potential treatments for sexual and bladder dysfunction in people with MS. And our first focus under that learning objective is to describe how treatment of sexual dysfunction for persons with MS should be targeted to the etiology of the dysfunction and the specific sexual dysfunction symptoms. That being said, if you would please, Dr. Page, take us to the clinic and start us out with a patient scenario.
So we have a 53-year-old, gravida 2, parity 2, postmenopausal woman. She has secondary progressive MS, and she's presenting for follow-up. You're getting your integral history, and she's not previously brought up these issues, but she's bringing up a new concern for sexual dysfunction. Now she's in a new relationship, and as you're asking about her symptoms, she mentions these painful leg spasms as well as decreased vaginal lubrication, which have made intimacy difficult with this new partner.
You're in the clinic asking this patient about her sexual dysfunction. Dr. Ross, what advice do you have for a clinician about opening what may very likely be a difficult conversation?
Well, first of all, you're right. It can be a difficult conversation, sometimes for both clinicians as well as for patients or their significant others. I think how you open this conversation in an MS clinic setting depends a bit on the setup of your clinic. You could use screening tools like the Multiple Sclerosis Intimacy and Sexuality Questionnaire 19, which is a form that takes about 2 minutes to fill out. This could be sent to a patient online ahead of the visit or done with a medical assistant as part of intake. And then the clinician could follow up and look at responses and discuss those with the patient in the office. Or the clinician could just directly ask the patient during the encounter if they have any sexual dysfunction symptoms. And if you go this route, I would recommend being specific and not being general. You could ask questions, for example, about saddle anesthesias, vaginal dryness, pain with intercourse, anorgasmia, erectile dysfunction, and try to normalize it too, opening with something like many patients with MS experience sexual dysfunction. Have you noticed any of these symptoms? So that the patient understands as their MS clinician why you're asking them and that may be part of their MS. Sometimes patients don't know. I would also recommend, if a patient says no, that they don't have any sexual dysfunction, to keep asking because that may evolve over the course of their disease, or they may be more willing to open up about it as rapport is established with their provider. I think it's also important to make sure you have gowns available in the clinic and perhaps chaperones if a patient does raise concerns, for example, about pelvic floor spasticity or some saddle anesthesia, where an exam of some of the more intimate areas is required to make them as comfortable as possible.
Dr. Page, is sexual dysfunction among persons with MS as common in men as it is in women?
So it can be challenging to put a percentage to sexual dysfunction in MS. For some of the reasons that Dr. Ross mentioned, this can be a sensitive topic. Reported rates are very variable, depending on country, culture, gender roles in different locations, as well as clinician behavior. So in different studies, for instance, 82% of women in an Iranian study, but only 35% of women in a Greek study report some level of sexual dysfunction. This can also be affected by how sexual dysfunction is defined, as well as kind of expectations for sexual function within the culture. We suspect that somewhere between maybe 40 to 80% of women and 50 to 90% of men with MS likely have some level of sexual dysfunction, but a meta-analysis has shown that that number is probably somewhere between 60 to 70% for both men and women, though this might manifest in different ways.
Talk to us specifically about how sexual dysfunction might manifest in patients with MS, doctor. What should the clinician be looking for?
Right. So there are a variety of different ways that sexual dysfunction can manifest itself in MS. Typically, we stratify that based on the etiology of sexual dysfunction, though the management differs in both men and women. So sexual dysfunction can be directly related to somebody's MS. We call this primary sexual dysfunction. This is, for instance, when a lesion in the spinal cord might cause saddle anesthesia, impaired ability to obtain an erection. And again, this is called primary sexual dysfunction, whereas the sexual dysfunction is directly related to injury to the central nervous system. We also have secondary sexual dysfunction. This is when symptoms of somebody's MS, things like fatigue, spasms, pain, paresthesia, that can make sexual activity difficult. Bladder incontinence is another one of these. And again, these are kind of secondary causes that might make sex challenging for patients, but doesn't directly kind of affect sexual activity. Lastly, we have tertiary sexual dysfunction. This gets at more of kind of the psychosocial, cultural, cognitive, and psychological factors that might affect sexual activity in our patients. Things like libido, sexual performance, as well as socially scripted roles in a relationship, all of those can affect our sexual function of our patients. So it's important to be mindful of our patients' mental health, how they perceive themselves. We find that even in patients with low levels of disability, low levels of kind of neurologic symptoms from their MS, even these patients report some level of sexual dysfunction. So again, it's important to be mindful of how people perceive themselves, how their relationship may have changed after their diagnosis, because this can also contribute to this tertiary sexual dysfunction.
Well, thank you, Doctor. Dr. Ross, if you would please, talk to us about the specifics of treatment for sexual dysfunction in people with MS.
So, treatment of sexual dysfunction is really varied. We try to understand, what is the causative part of the sexual dysfunction? Is it primary, like Dr. Page was saying? Is there a secondary factor like spasticity or paresthesias that's getting in their way? Is it tertiary with psychological components, and target their treatment relative to the type of sexual dysfunction that they're having? For some examples, if a patient is having spasticity in their lower extremities and that's limiting their sexual function, we often think about botulinum toxins or perhaps use of baclofen, although you need to be wary of baclofen potentially causing drowsiness or subtle weakness, of course, with both of those agents. If, on the other hand, a patient has dryness, vaginal dryness, which may be from directly from their MS or a side effect of their other medications, we're typically thinking about water-based lubricants. If it's painful paresthesias, we might think about neuropathic pain medications like gabapentin or other anti-epileptics. Of course, with gabapentin, you also may have to watch out for drowsiness or the potential for some encephalopathy to come with that. If a patient is having sort of multifactorial causes, a couple of things that I find helpful are pelvic floor muscle therapy can be a nice way that's non-pharmacologic without adding to their medication regimen to help work on both their response to sensation as well as their spasticity as one option, and also being thoughtful if any medications that they're already taking could be eliminated instead of adding something else. If they're on a serotonin reuptake inhibitor, perhaps for depression symptoms related to their MS or pain, that could be contributing to sexual dysfunction, and seeing if that could be removed or reasonably switched, for example, to bupropion or something that does not have as much sexual dysfunction side effect would be a good option too. Several other medications clinicians should be aware of that can cause sexual dysfunction that may be used in our MS patients are 5-alpha reductase inhibitors like finasteride, retinoids, like I said, tretinoin, alpha blockers like prazosin, and several of the antihypertensive classes, particularly beta blockers or thiazide diuretics, may cause sexual dysfunction. And there may be some other opportunities to switch medication uses to alleviate sexual dysfunction in MS patients.
Now, the patient in the scenario you presented, she described painful leg spasms and decreased vaginal lubrication. Based on what we've been discussing, Dr. Page, what approach would you take with her?
Yeah, so Dr. Ross outlined actually some of the treatment modalities that we can use for this patient. So I think, first of all, it's important to elucidate, especially with things like vaginal dryness, if there's any other contributing factors, and this is where working with a gynecologist or urologist might be helpful too. So it's important to elucidate whether that dryness might have been progressing since menopause, or whether this is a new symptom that's potentially related to her MS. So I think it's difficult without more information to determine whether it's primarily a neurologic or a gynecologic cause in a postmenopausal woman. But regardless of the cause, water-based lubricants are very helpful. Referral to gynecology for this patient actually revealed that she does have some degree of vulval vaginal atrophy, which can be a postmenopausal symptom. And she was started also on topical estrogen, which can improve both those symptoms of dryness as well as the atrophy. And sometimes folks have pain with sexual intercourse, although this patient did not. For spasticity, with her leg spasms, there's a few different options. So just like Dr. Ross was mentioning, this patient can work with physical therapy. People do have good outcomes with pelvic floor physical therapy to strengthen those pelvic floor muscles, but also to identify less painful positions. If this is related to leg spasms, they can work with them for that too. And then we mentioned baclofen. So there is the side effect of drowsiness. So typically, if we're using baclofen for sexual dysfunction for these spasms, generally we'll use kind of a timed method where you can take baclofen 30 minutes before sexual activity, and then you get some of the benefits of kind of that anti-spasticity effect, and then the drowsiness is maybe less interfering with somebody's sexual activity. This patient did have some side effects of baclofen and ended up starting on botulinum toxin A injections.
Thank you, doctors. Our key learning point for this part of our discussion is to describe how treatment of sexual dysfunction for persons with MS should be targeted to the etiology of the dysfunction and of the specific sexual dysfunction symptoms. What are the most important things you'd want our learners to take back to their practices? Dr. Page?
So I want people to know that sexual dysfunction affects the majority of both men and women with MS. It's often underdiagnosed and undertreated. It's important to take some of those things that Dr. Ross mentioned. So really making sure you have a chaperone, asking people who are in the room with the patient, and could be family members, could be a partner, to leave the room so that you can get a private interview. The next thing that I would say is you can have multiple causes of sexual dysfunction. Can be directly related to somebody's MS or direct central nervous system demyelination, but it could also be secondary to spasticity or pain or fatigue. But it's also important to consider more complex psychosocial factors. The relationship that somebody has with their partner, depression, cognitive changes can all affect sexual function as well. I want neurologists to be mindful that you should consider the possibility of urologic or gynecologic causes of sexual dysfunction. So, utilizing your referrals and working in an interdisciplinary team, utilizing comprehensive care and referring out when needed to get some help from our colleagues. And then you can manage sexual dysfunction both with pharmacologic agents like baclofen, as well as non-pharmacologic therapies like physical therapy, pelvic floor, muscle therapy as well.
Nice summation. Thank you, Doctor. And we'll return with Dr. Lindsay Ross and Dr. Elizabeth Page from the Cleveland Clinic in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's E-Multiple Sclerosis Review program, focused on the prevalence and potential treatments for sexual and bladder dysfunction in people with MS. Our guests are Dr. Lindsay Ross and Dr. Elizabeth Page, MS specialists from the Department of Neurology at the Cleveland Clinic. And we've been speaking about how treatment of sexual dysfunction for persons with MS should be targeted to the etiology of the dysfunction and the specific sexual dysfunction symptoms. Let's turn now to our second key learning focus. Explain how treatment of the lower urinary tract symptoms common in persons with MS often depends on whether symptoms of overactive bladder or of urinary retention predominate. So if you would please, Dr. Ross, take us back to the clinic with another patient scenario.
Of course. So this was actually just a few weeks ago. I saw a 52-year-old gentleman who had secondary progressive multiple sclerosis, who had come to my office accompanied by his teenage daughter. And he'd had infusion treatments before my visit, which was then in the afternoon. And unfortunately, he had an episode of urinary incontinence in the exam room. This was his third or fourth appointment with me, and he had never mentioned bladder dysfunction before that day.
Dr. Page, have you found patients are more open to talking about bladder dysfunction than they are about sexual dysfunction? What's your experience been?
I think both can be hard. So bladder dysfunction can be a big hit to self-esteem for patients. Openness, varies based on gender, cultural background, as well as your relationship with the patient. Seems like women are more open, especially postpartum women are more open to bladder changes and kind of any kind of dysfunction with urinary continence than men tend to be. But can be helpful to inquire about bladder dysfunction just as a standard part of every visit. Similar to sexual dysfunction, so you can have an MA do it as part of a pre-visit questionnaire, or you can ask directly during your time with the patient. But it's helpful to tell patients, it's safe to talk about it, that it's common, not require them to bring it up, to directly ask people about bladder dysfunction. And then again, especially in this case with somebody with a teenage daughter in the room, it can be helpful to ask others to leave the room, at least for this portion of the visit.
Very good. Thank you, Doctor. Dr. Ross, you mentioned bladder dysfunction happens often in MS, but really, how common is it?
It's a little bit hard to put numbers on it. Similar to sexual dysfunction, it depends a bit on how you define the scope of the problem. And people have varying willingness to be forthcoming about their symptoms. As Dr. Page was just mentioning, when we talk about the scope of the problem, are you talking about just detrusor muscle or sphincter issues, or do you include people who have mobility problems that make it hard to get to the bathroom, or cognitive dysfunction that makes it hard to alert family members or caregivers to the fact that they need to use the restroom, right? Does that count or not? So different studies sort of line this up differently and come to some variable numbers. And similarly, I mentioned patients can evaluate even when it's their own opinions sort of differently. Someone might go to the bathroom one time an hour, and one person would rate that as very frequent, and another person would say that's not a problem. Maybe one of the better ways we've seen numbers put on this, there was a large systematic review and meta-analysis looking at MS patients in across global studies, and it looked at just incontinence as one measure of bladder dysfunction. And what they found was that 41% of persons with MS had urge urinary incontinence, 26% had stress urinary incontinence, and 18% had a mixed form of urinary incontinence. And of course, as mentioned, incontinence is just one form of bladder dysfunction, and we're coming in, for urge urinary incontinence, just under 50% of people. So I bet, around the majority of persons with MS have some form of bladder dysfunction.
Thank you, Doctor. So, what can you tell us about how overactive bladder symptoms are treated in persons with MS?
So you can approach this several different ways, and maybe I'll start with the pharmacological therapies. Antimuscarinics, such as oxybutynin, are often used as first line. Oxybutynin and antimuscarinics block parasympathetic activation of the bladder muscle, the detrusor muscle. But while these are sort of considered first line and commonly used, they do have quite a number of side effects, and those include constipation, increased fatigue, cognitive dysfunction, a number of symptoms that people with MS often already experience. So about 50% of people do discontinue use of antimuscarinics when they're prescribed for bladder dysfunction. Other options on the pharmacologic side are tricyclic antidepressants that have more prominent anticholinergic components. These would be drugs like amitriptyline or imipramine, can be used to help someone hold on to their urine longer, and maybe you'll get some additional benefit on mood or neuropathic pain, but again, may come at the cost of some sedation or perhaps even urinary retention that can be problematic. And then lastly, from the pharmacological side, beta-3 adrenergic agonists like mirabegron have been used. These are known to relax the detrusor muscle, but they've had mixed reviews and studies for MS. They've actually not been shown to have a significant increase on bladder capacity for persons with MS, but in patients' studies where they self-report on overactive bladder symptoms, mirabegron and similar agents may have some benefits that patients report.
Please continue, Dr. Ross, and tell us about non-pharmacologic methods.
Sure. Given some of those complexities around the pharmacological therapies, many of us start with or think about non-pharmacologic interventions for overactive bladder. In particular, pelvic floor muscle therapy and posterior tibial nerve stimulation have the most evidence for people with multiple sclerosis to treat overactive bladder and have shown good benefit across overactive bladder symptoms. If those therapies are not sufficient for a patient and/or pharmacological therapies that cause side effects or are not tolerable, another option, often working with urology, would be to consider intravesicular botulinum toxin injections.
Those are the options for treating overactive bladder in persons with MS. Dr. Page, what do clinicians need to know about treating urinary retention symptoms in persons with MS?
So this depends on the cause. We want to be mindful that both outlet obstruction and detrusor hyporeflexia can cause retention. So if this is obstructive, of course, we'd want to treat any kind of prostate enlargement or bladder stricture. If it's related to detrusor sphincter dyssynergia, you could consider things like alpha adrenergic antagonists like terazosin that inhibits bladder neck contractions. You can also consider things like sphincter botulinum toxin or sphincter dilation, or even consider things like sphincterotomy. If, however, things are related to detrusor hyporeflexia, botanical cholinergic agonists are rarely effective. So oftentimes these patients actually need intermittent self-cath preferably if somebody has that ability. Otherwise, you can consider things like chronic cath or urinary diversion for these patients.
Thank you, Dr. Page. Let's go back now to the patient we started this discussion with, the gentleman with urinary incontinence. Dr. Ross, how did you end up treating him?
So, as Dr. Page brought up before, the first thing I actually did in this case was have the gentleman's teenage daughter leave the room. Actually, sent her with one of my nurses to go get an extra pair of scrub pants for the patient to wear home. And then once his daughter was out of the room, we discussed his symptoms in more detail. He was willing to admit at that point that bladder dysfunction, that this was not a one-off episode for him, that this had been something that had been a problem for several months. And I spent some time clarifying with him whether there were any urinary retention symptoms, whether he had, to try to empty his bladder twice or, within 5 minutes, or whether he'd had any urinary tract infections, or whether it was just overactive bladder and urge incontinence. And after discussion, it seemed to be more just overactive bladder and urge incontinence for him. And he clarified there were no other new or worsening MS symptoms, that this was a sign of a larger relapse, but just more of a chronic part of his disease that had just not been attended to previously. So we discussed options. I offered him antimuscarinic therapy, particularly oxybutynin, or the choice to do pelvic floor muscle therapy. And he chose pelvic floor muscle therapy. And when I saw him back in the clinic about 3 months later, he was very happy to report he was not having any more episodes of incontinence. He still had some urgency symptoms, but he felt that his bladder dysfunction was substantially better controlled.
Very interesting case, doctors. Thank you for bringing it to us. So our key learning point for this part of our conversation is to explain how treatment of lower urinary tract symptoms common in persons with MS often depends on whether symptoms of overactive bladder or of urinary retention predominate. What are the most important ideas our learners should take away from our discussion? Dr. Ross?
So first, I'd say when you look across the global MS patient population, just under half will have urge urinary incontinence, and more than that likely have some form of bladder dysfunction. So this is going to be there in the majority of your MS patients. And the willingness to talk about that or bring up symptoms, as Dr. Page was discussing earlier, may vary, and it helps if the clinician brings this up and does not just sort of wait or expect the patient to do so. So making this part of your routine visits with patients would be really helpful. And then in terms of treatment, if this is overactive bladder, the pharmacological options often have some side effects or limitations. So you may want to consider pelvic floor muscle therapy or posterior tibial nerve stimulation, both of which have good evidence for persons with multiple sclerosis. If it's urinary retention symptoms that seem to be the issue, and the cause is detrusor sphincter dyssynergia, you could think about alpha adrenergic antagonists may be effective, but otherwise, as Dr. Page was bringing up, you may want to consult with the urologist to think about catheterization or diversion options.
From the Department of Neurology at the Cleveland Clinic, Dr. Lindsay Ross, Dr. Elizabeth Page, thank you for sharing your knowledge and expertise in today's multiple sclerosis review program.
Well, thank you so much for having us. It was a pleasure to be here. We think these are very important issues for our MS patients, so we really appreciate the time.
Thanks so much for the opportunity.
For multiple sclerosis review, I'm Bob Busker.